User-WZ5CD8HV3L writes, "Hello, I would like to ask you if you have observed during your clinical experience any correlation/cause between Class 2 Division 2 malocclusion and TMJ dysfunction. I would also like to ask if it's common in these types of malocclusions the condyle to be posteriorly dislocated, or is it usually mainly a dental problem? I have a Class 2 Division 2 malocclusion, and it feels to me that it is uncomfortable to close fully my mouth. Rather, I prefer keeping my mandible slightly down and forward, and I also noticed that I do that when I am eating. I am a heavy eater, so what I noticed is that I prefer to take big amounts of food so that when I chew, my teeth don't really touch. Rather, a piece of food is between them. Just a few observations and questions for what it seems to be a very underdeveloped/difficult field, TMJ disorders. Thank you for the clarity and wisdom you offer through your YouTube channel. It really helps a lot, and I'm sorry for my English. I'm from Europe." Thanks for the question, and thank you for the kind words. And your English seems fine to me. The short answer is yes, I do observe exactly what you're describing pretty regularly, and I'll tell you why I think that is and what can be done to correct it. First, let's define what we consider to be a normal or Class 1 occlusion. When we examine the incredibly intricate design of the teeth and how they fit together, we can see pretty clearly that the lower teeth are designed to fit inside the upper teeth. In other words, the upper teeth fit over the lower teeth, kind of like a lid on a jar. This creates what we would call an overjet, which is the amount of horizontal overlap where the edges of the lower front teeth are set back a little bit behind the edges of the upper front teeth, and then the overbite, which is the amount of vertical overlap between the front teeth, or how much those lower teeth disappear behind the upper teeth when a person closes all the way together. And an overbite is normal. Let me repeat that. An overbite is normal. I meet way too many people who are under the impression that the front teeth are supposed to fit together edge to edge, and that is not the case. Mechanically, that's not even a good situation. There's supposed to be a little bit of overlap so that we can use the front teeth like scissors to cut through food. Imagine trying to cut paper with scissors that fit together like this. 1 to 3 millimeters of overbite and overjet is considered to be normal. Class 3 malocclusion is when the lower jaw is set forward either because of a lack of growth in the upper jaw or maxilla or excessive growth in the lower jaw, or often a little bit of both. A Class 2 malocclusion is when the buccal groove of the lower first molar or 6-year molar is lined up behind the mesiobuccal cusp tip of the upper first molars. This is an indication of a lack of horizontal growth of the lower jaw or mandible, and this can lead to difficulties with breathing and swallowing. Many of us also believe that this leads to a forward head posturing. Now, a Class 2 Division 2 malocclusion is when the lower teeth are set back, kind of like in the regular Class 2, but the upper front teeth are inclined inward, and this gives the appearance or the illusion of a normal Class 1 relationship. Usually, this gives the appearance that the lateral incisors are flared or rotated, what some people might call a snaggletooth. I don't think there's any real consensus as to why this happens, but if we think about it mechanically, the teeth move in response to the changes in forces being applied to them. And this is how braces work. But the forces can also come from the lips and the cheeks and the tongue and the clenching muscles. And the most frequent repetitive pattern that engages these muscles, and we all do this a few thousand times a day, is swallowing. My theory is that a Class 2 Division 2 malocclusion develops, at least in part, because of the forces from the lips during swallowing. I do think there's a hereditary component here in the development of both a Class 2 and a Class 3 malocclusion, but we can't really do too much about heredity. We can influence the functional component of growth and development, and this is where I think orthotropics and myofunctional therapy shine. So let's get back to swallowing. If there's a big gap between the edges of the upper and lower front teeth, the muscles of the lips and cheeks are going to have to make accommodations in order to carry out an effective swallow. Either the tongue is going to reach forward and fill that space, which is what we commonly call a tongue thrust, or that lower lip might drive up behind those upper front teeth, or that lower lip could wrap in front of the upper front teeth in order to create a lip seal, and that would establish a pattern that would pull backwards on those upper front teeth. And this isn't tested and established scientifically, it's just my hypothesis. But if you have a situation where that lower jaw just isn't fully developing forward, and you're growing into kind of this weak chin situation like me, then it's going to likely feel more comfortable and actually be more healthy to allow your jaw to rest in a position that's a little forward compared to your habitual occlusion where your back teeth fit together. This is what I call protrusive posturing, and I see people doing this all the time. And this is what I think you're trying to describe when you say you're more comfortable with your jaw sitting a little down and a little forward. So now let's get back to the division 2 part of this. If the upper front teeth are tipped backward, then that makes it a little more difficult for that lower jaw to settle forward into a more comfortable position. And if you have an anxious or intense personality, then this restriction in forward movement will predispose you to developing problems in your jaw joints because of the compressive strain that's persistently applied to these structures when the mandible is squeezed into that retracted position. So what's the solution? The first step is diagnosis, and in my practice, this would be a CT scan and a comprehensive examination. In an orthodontic practice, this might involve a cephalometric analysis, and it's important to pay attention to posture and swallowing patterns while we look at these problems. If it were me, I'd be looking for an airway-focused orthodontist or one who is well-versed in orthotropics. In my practice, the way I approach this is if I determine that the habitual position and movement patterns of the lower jaw are a likely cause or contributing factor of the patient's symptoms, then I'll design an orthotic device, sometimes two, one for daytime, one for nighttime. And then after several weeks of my TMJ rehab program, if the patient's symptoms are improved, it would stand to reason that orthodontic changes to reposition those anterior teeth might be beneficial. But if you decide to do this, it's important to do some myofunctional exercises to establish new patterns and habits. Otherwise, your teeth are just going to want to go back to where they started. Anyway, hope this helps, and thanks for the question.